Hello, good evening, everyone. I, Dr. Mehul Thakkar, on behalf of Indian Association for Bronchology, invite you to the 10th webinar in the EBUS series. This is an initiative by IAB to inculcate and spread the IP knowledge across the nation. We've had up till now 9 webinars. This is going to be the last in the series, and believe me, we have saved the best for the last. You have to attend at least 8 live webinars for at least 90% of the time and attend one of the physical workshops in which will be conducted subsequently in each zone of the country. So one workshop and 8 live webinars to get the EBUS certification course from Indian Association for Bronchology. Now, before I move ahead to today's webinar, I would like to take this opportunity to invite you to our very own NAPCON, which is happening in Pune in the next 3 weeks. Can you put up the slide, please? So as part of the managing or organizing committee, I invite you for our own, very own NAPCON Pune. And I can assure you the scientific program is going to be up to the standards that you expect. It is going to be full of new ideas. It is going to be full of knowledge, and you would not want to leave the halls. So please join us for this academic feast from 23rd to 26th of January, which will be held in JW Marriott Hotel in Pune under the leadership of Dr. Nitin Abhyankar. Now, back to our webinar today. Today's webinar is special. We've had a very interesting faculty up till now, but we have saved one of the best faculties till now. It is my honor to introduce Dr. Vivek Nangia, sir. He's an internationally renowned interventional pulmonologist with over 2.5 decades of experience. And he is the only pulmonologist to be classified in infectious disease from London University. If you go and read the amount of felicitations he has received, I'm sure the whole webinar would not be enough. He has received most of the coveted awards, the icon of respiratory medicine, most inspiring doctor. He's won best pulmonologist awards, and he has been conferred upon fellowships by ACCP in USA, IDSA from USA, NCCP, ISCCM, IAB, and Indian Sleep Disorders Associations. He is the member for guideline forming committees from management of invasive candidiasis in ICU from Asia Pacific region, diagnosis and treatment of IPF in resource constrained settings, bronchoscopy in COVID patients, and many, many more. He had a role to play in the EBUS guidelines for India, so it's an honor to hear from him. He has played a pivotal role in promoting and advocating antimicrobial stewardship and adult immunization. I can go on and on about him, but I think it's time now I hand over the stage to Dr. Vivek Nangia.
Thank you, Mayur, for those kind words of introduction. Really, I mean, this wasn't really required, yeah, but so sweet of you. But okay, guys, I'm so glad and so happy to welcome you all to this 10th edition of the IAB the webinar on EBUS. This is the last one, but believe me, this is going to be the most interesting one because we are taking EBUS beyond its usual indications. So, and for that, we have a galaxy of stars with us this evening. As you can see, we have first a talk by Dr. Rakesh Chawla. Dr. Rakesh Chawla, who's been a part of the EBUS forming guidelines himself and has been holding various conferences and is a renowned interventional pulmonologist, not only in Delhi, but across the country, and not just the country, but internationally as well. He's a member board of regents for the World Congress of Bronchology and Interventional Pulmonology organizing chairman for NAPCON 2023. I don't think anyone would be there in this country who doesn't know him if he's been in pulmonology even for a few years. He's been a recipient of the prestigious Dr. A.S. Pental, R.C. Jain, O.S. Sharma, various other awards as well, and has also been honored by the former President of India. He's been the past chair of the Rare Lung, Airway and Pleural Disorders for WAPIP and is currently working as consultant and chairman of respiratory medicine, critical care and sleep disorders at the Jaipur Golden Hospital, and has been conferred with appreciation award by Dr. APJ Abdul Kalam, the former president of our country, the member governing council of ICCI and vice president of the Indian Society, president-elect of this IAB, whose webinar we are all attending. So, Dr. Chawla, welcome. And I think we'll start with your talk first, followed by the panel discussion, and I'll introduce the panelists later on. So, this talk is going to be about EBUS beyond Mediastinum. So, EBUS, as you all know, was basically devised to access the lymph nodes in the mediastinum. That is where it all started. But as we've experienced for various other drugs also and various other equipment also, that when you have something you want to use maximal, I mean, you have to optimize the usage of that instrument or device or the medicine. So now we have taken the EBUS beyond the mediastinum. So first EBUS took us beyond the airways, and now EBUS, we are using it beyond the mediastinum. So I'll request Dr. Chawla to start his presentation and enlighten us on where all can we use EBUS and how safe it is, and what can be the various complications that you can encounter while doing it. Dr. Chawla, over to you.
Thank you, Vivek, for the kind words. Thank you, Indian Association for Bronchology. Amita, doing a leading role of this joint venture of certification of various subspecialties in field of interventional pulmonology. I start with the guidelines. If anybody who is starting EBUS must go through these guidelines made by Indian Association for Bronchology for the country. That is an initiative taken, and the lead was taken by All India Institute of Medical Sciences. Another paper you must read before venturing in EBUS is a technical aspect of endobronchial ultrasound guided transbronchial needle aspiration. A wonderful paper which enlightens you, and you know what you are going and how you are going to do. Now, EBUS has emerged as a new, hello? Share button. 1 minute. What I do now? Escape. Okay. What do I do now? Share. Share. Okay. Share. Share. 1 minute. No, this is my PowerPoint open now. No, I again join.
Dr. Chawla, Dr. Chawla, hi. So what you do is that you please press the button share.
The share is in the corner, coming in the corner.
Yes, you please press on it.
I clicked on share.
Yes.
With share or link to this slide?
No, you do the share screen.
Shares, the share recipients you select will receive a notification email.
No, share screen. Share screen.
Share screen.
Also your...
Share in the Zoom meeting screen.
Okay, okay. This is a Zoom I came. Now I share.
Center below.
Okay, center below. Now share. Now share. You are sharing the screen?
Yes, yes.
Now I press on this. How it is visible? Full screen. Okay. Now it is the full screen. Okay now?
Perfect, perfect. Thank you so much.
Okay. Thank you. Okay. Right. So I'll just take a minute to again start. So as I have said, this is a joint venture by Indian Association for Bronchology making the guidelines. I am thankful to Indian Association for Bronchology and the gigantic task done by Amita for subsets of super specialty of chest of IP making the certification courses. And these guidelines, any beginner must read before venturing into EBUS. Comes another wonderful paper from chest, technical aspects of EBUS. You read these two, you know what you are going to do in EBUS. EBUS has emerged as a new tool to see beyond what bronchoscopists are used to see. I used to say the Gandhi of the chest specialist is the bronchoscope. Now, this is the third eye of a chest specialist when he can see beyond the airways. The radial probe allows high-resolution imaging and the multi-layer structures of the bronchial wall as well as the evaluation of surrounding structures. EBUS TBNA has also extended beyond the endobronchial and thoracic boundaries to sample lesions from the liver, left adrenal glands, retroperitoneal lymph nodes. This is by virtue of EUS-BFNA. EUS-BFNA and EBUS TBNA, when combined together, you are able to scan almost all the mediastinum. EUS-B helps you to access the anterior and superior. You can access it with EBUS. Inferior and posterior, you can access with EUS, and you can scan the whole mediastinum. Coming to today's talk of EBUS, newer frontiers beyond mediastinum. Now, since this is the last webinar, I will take you few slides of the introduction of EBUS. It came in 2005, the EBUS TBNA. These are the pioneers of developing the EBUS, Krasnik, Yasufuku, and Felix Hunt. This is a new dawn for respiratory physician in India, and EBUS is a new minimally invasive technique that expands beyond the view of bronchoscopist, beyond the lumen of the airways. It's a car with a GPS. You know where you are going, one of the most safe procedures. You need skill to maintain minimum amount of EBUS to be done every year to maintain the skill. Whether in conventional TBNA, you learn by the method and modality. You will be surprised, in a country of 140 billion, we have only 415 plus EBUS, and maximum 50 R is the latest data in Delhi and NCR alone. We think it's an epidemic of mediastinal lymphadenopathy. No. Everybody wants to park the Mercedes in his garage. Just have the look of the instrumentation of the EBUS tower. This is how the EBUS scopes looks like. A beautiful, wonderful photograph you must imbibe in your mind whenever you are doing the IP. There are two major vessels on the left side, aorta and pulmonary artery. Two vessels on the right side, brachiocephalic and azygous. 4L, 4R, and 7 does your job around 80% for diagnostic modality. You are a beginner, try to do everything on the right side, you will be never in trouble. And gradually when you gain an experience, venture on the left side or anywhere you want to venture in mediastinum. So this is a picture for any IP fellow practicing IP, whether EBUS or doing stenting or doing cryo or doing ablation or doing any work of IP, you must know this photograph of vascular anatomy and the lymph node stations. Diagnostic indications for EBUS are the diagnosis of the hilar and mediastinal, TB, sarcoid, CA lung metastasis, staging of lung cancer, diagnosis of mediastinal tumors, diagnosis of solitary pulmonary nodules, evaluation of endobronchial tumors, and see the direct invasion of pulmonary arteries like sarcoma. The newer indications, lymph node staging and diagnosis, we know. Now we are going beyond mediastinum. Diagnosis of pulmonary lesions adjacent to the airway. Learn to go through the esophagus, EUS-BFNA, approaching left adrenal gland, liver metastasis, paraesophageal, pulmonary or pleural lesions. Diagnosis of lesions, sarcoma versus embolism. Diagnosis of pulmonary pleural lesions adjacent to the mediastinum. These are the expanded indications. The talk is into three parts. First, the diagnosis of pulmonary lesions adjacent to the airways. Second is the diagnosis of paraesophageal lesions through the EUS-BFNA. And third part is the rare indications of EBUS, where all in the literature it has been applied. So EBUS TBNA for the diagnosis of central parenchymal lung lesions which are not visible at bronchoscopy, and the diagnosis of malignancy, it has been proved in 77% of patients with a centrally sited lung lesion that was not visible at routine bronchoscopy. Another paper of endobronchial ultrasound guided transbronchial needle aspiration of the central lung parenchymal lesions adjoining the airways. The diagnosis was in 86.4% of cases, and it should be considered the procedure of choice for centrally located lesions without endobronchial involvement. EBUS TBNA for the diagnosis of unknown pulmonary masses in another paper has been 94.1 to 94.3% respectively. A case of parenchymal lesion on the right side, paratracheal, and you approach this lesion and puncture. See, the basic principle is you are able to handle the EBUS scope and the ultrasound probe to abut to the lesion. That is an art to manipulate the scope in various positions. Talking is very easy. When you are holding a scope and when you have to negotiate near the masses, that is where the real skill comes, which comes with the experience. And you puncture that area and get the material. Another case of the right-sided pulmonary lesion, paratracheal. So the CT demonstrates a tumor in the left apex adjacent to the trachea and demonstrates the tumor. EBUS transbronchial needle aspiration is done and patient found to have the adenocarcinoma. Another case of anterior mediastinal tumor suspected of malignancy. EBUS demonstrates the tumor in the back of the brachiocephalic vein. EBUS transbronchial aspiration scanned and the tumor is diagnosed. A case of mass abutting the right lower lobe bronchus. Incidentally, it happened, we did it today. So I said, why not to incorporate? This is the mass and this is the adjoining right lower lobe bronchus where you abut the scope and you are able to puncture. These are the CT scans and this is how you are puncturing the mass. Since today pathologist was not there, so we could not have the rows that we have done today. You can see at 434, then I said, let me incorporate into this. I have taken the few slides from Gasparini's collection to show you again how the scope is getting abutted to the paratracheal, parabronchial airways, and you get the material. This is a diagnosis of pulmonary lesion adjacent to the airway, and the diagnosis of small cell carcinoma has been made. Diagnosis of pulmonary lesion adjacent to the airways. The mole is 1 centimeter in relation to the posterior wall of right main bronchus. And once you localized, you created the image. It's very easy to differentiate the parenchymal images or the lymph node images and came out to be the adenocarcinoma. Another case of hematoma in relation to the posterior wall of the right main bronchus. This is anterior wall of left upper lobe bronchus and the diagnosis is adenocarcinoma. Diagnosis of pulmonary lesions adjacent to the airways and you can see this came out to be adenocarcinoma. Another case of right middle lobe, you wedge the bronchoscope in the middle lobe towards the direction of the mass and you get a diagnosis. And the diagnosis was adenocarcinoma. Metastasis of urothelial cancer, a lesion difficult to approach. The EBUS has to be wedged and the help of C-arm is taken, and it was an 8 millimeter bronchus where the scope was wedged and the lesion was identified and the node has been punctured and it was metastasis from urothelial cancer. Another left lower lobe lesion where the bronchus EBUS is wedged and you get the diagnosis. Nodule in the left upper lobe, you can see this. You wedge your scope here, identify the lesion and puncture the diagnosis for adenocarcinoma. So another very beautiful slide, when you have a lesion which is paratracheal and it is not just abutting the trachea, you can move the trachea with the EBUS scope. See, the beauty is that EBUS scope, if you move the trachea, you can approximate that lesion and you can puncture it and get the diagnosis, because the trachea is again a flexible structure. Second part, I'm sure now, by now you have fair idea about the paratracheal, parabronchial lesions, and you can puncture them with the EBUS. Next part of the talk is paraesophageal lesions. Esophagus is a superhighway. You have a new way and a new way for interventional pulmonologists to work on. There is no cartilage, there is no cuff, it is better tolerated. Lymph node stations not in contact with the airways, 8 and 9, even 5 and 6. Paraesophageal lung lesions, paraesophageal pleural lesions, liver metastasis, left adrenal gland metastasis. You can approach with EUS, BFNA. This pulmonologist should know. And there are pulmonologists who only do EUS, BFNA with the EBUS scope rather than venturing into the bronchus. So, pulmonologists are performing the esophageal needle aspiration of the parenchymal lung lesion using the EUS-B, which is very, very helpful to the lesions which are adjacent to esophagus. These are the publications you can go through where the lung lesions are approached through the esophagus, through the EUS-BFNA. Left adrenal, you identify the seagull sign and you are able to puncture the adrenal. Liver metastasis, when you see the left lobe of the liver, you can see the metastasis and you can puncture. EUS-BFNA is considered where inaccessible EBUS TBNA or radial EBUS, or where expected yield of radial EBUS was low, or where anesthetist concern suggested an esophageal approach will be preferred, or following EBUS staging of mediastinal lymph node, rapid on-site examination did not demonstrate definitive diagnostic findings. EUS-BNA is diagnostic in this study in 96% and sensitivity is 100% with 95% confidence interval observed in both parenchymal lung cancer and pulmonary metastatic lesions. Paraesophageal pulmonary lesions, if you see the esophagus and you are able to see these lesions and you are able to puncture these paraesophageal lesions, you identify, it's not a very big deal doing EUS-BFNA. You must identify 2-3 structures when you are doing, and you are able to abut to that level, identify the lesion. The small lesion close to esophagus, again you identify in between is an aerated lung little amount, but you puncture and you get a diagnosis. Paraesophageal pulmonary lesion and came out to be the carcinoma. Large mass of left upper lobe adjacent to esophagus and not to trachea, and you are able to puncture. It's more or less the case we did today. It was the right middle lower lobe bronchus abutting to this tumor. Large lesion in the apex of the lung and pleura, and through esophagus it was easy to reach and puncture and diagnose. Paraesophageal PET positive 2 years before right upper lobe lobectomy was done for adenocarcinoma, and you can approach it through the esophagus and puncture this and you can get the diagnosis. Another case, PET positive, diagnosed with EUS-BFNA and came out to be the mesothelioma. You can see the approach from esophagus. You have to tune your eyes to identify, and able to do the diagnosis. ESP-FNA for adrenals, livers, and retroperitoneal lymph nodes is also the equipment of choice. Up to 7% of patients with resectable cancer have adrenal masses, which in approximately 2/3 cases are benign adenomas. And Kronberg has reported the diagnostic yield of left adrenal glands EUS-BFNA was comparable to that of conventional EUS-FNA performed with gastrointestinal echoendoscope. So you can think of the EBUS used for adrenals FNA or the endoscope, gastroendoscope used for the FNA. The results are comparable. These are all the publications for these papers. This is what Siegel sign I was talking about. You are able to identify this Siegel sign, which is of the adrenals. And when you have the metastasis, you are able to puncture and get the report. Third part of the talk, uncommon uses of EBUS scope, which is more interesting. Genotyping of tumors. The EBUS TBNA material is adequate. In this study of 126 samples obtained via EBUS TBNA, mutation analysis were performed for epidermal growth factor receptor and Kirsten rat sarcoma with success rate of 97%, 93% respectively. You can further genotype with these markers and you are able to get enough material with EBUS TBNA. Fiducial markers. You just put it, remove the stellate, load the needle with the fiducial markers and place it with the stellate. After localizing the lymph node, metastasis, lung tumors where you want to do a brachytherapy, you want to do a radiation therapy, you want an ablation, you can use the fiducial markers by localizing the lesions with EBUS, and with the EBUS needle you can always place these fiducial markers. As I have said, the pleural lesions are easy. Even cardiac tumors can be accessed with EUS-BFNA. There are the cases reported are two cases of EUS-BFNA of the left atrial masses. Usually choice used to be the open heart surgery, but they have been reported with high accuracy and no adverse events. As I said, the posteriorly, you can view the mediastinum. Pericardial and pleural effusions. The effusion which is not accessible, EUS-B guidance help to drain the pleural effusion, and it has been reported by DeWitt and colleagues. Endobronchial ultrasound, the posterior loculated pericardial effusion has been tapped with the EBUS after localizing it. Staging of thyroid malignancy, EBUS has been used for staging in patients with lesion is not amenable to percutaneous biopsy. There are case reports and there are editorials about the use of EBUS for puncturing the thyroid nodules. The two cases and the report, systemic review of literature has been done in Lung India by Dr. Karan Madan and the All India Institute team. Airway lesions, invasion has been diagnosed with the EBUS where the esophageal cancer and thyroid cancer, there was an invasion. Another indication is the mediastinal vessel where you can differentiate pulmonary embolism and sarcoma. EBUS, for the first time, in real time, a blood clot floating into the right main pulmonary artery, not infiltrating the wall of the blood, made a correct diagnosis of pulmonary embolism by Cassoni and workers. And multi-center pilot study showed that EBUS had an accuracy of 96% in detecting pulmonary embolism. Endobronchial ultrasound helps in detecting the emboli when PE is suspected strongly in intensive care and patient cannot undergo a CT scan. EBUS bedside can be performed for the diagnosis of pulmonary embolism. The accuracy is to that extent that you can rely on the EBUS finding to diagnose pulmonary embolism. Sarcoma. you need to suspect involvement of the wall, you puncture the pulmonary artery, and you get the adequate amount of material to diagnose the endovascular lesion and the pulmonary sarcoma. These are various literature for EBUS TBNA in diagnosing pulmonary artery sarcoma, and you can have this and go through in details. Another interesting case, we came across a case of hemoptysis. Chest X-ray was left lower lobe consolidation. Left main bronchus, this lesion was visible. We did not venture to biopsy it. There was a suspicion it can be a Delphi lesion, and we confirmed it was communicating to the underlying vessel, and had you punctured it, you would have got a massive bleed. This is another beautiful indication that you can diagnose Delphi lesions and their communication with underlying vessels. Another indication is a mediastinal cyst. Now there is a debate. The treatment in symptomatic, asymptomatic patients is the surgical, where there is no issue. But if you have a patient where you can have a long-term follow-up, you can have local aspiration by the EBUS, and you see the materials subjected for the histocytology was all epithelial cells. So you have primarily surgery as a choice, but there are patients where surgery is not possible and patient is symptomatic. You can take the EBUS help and drain the mediastinal cyst with the follow-up that patient is accessible to have if there is any recurrence or not. Another new indication has developed, the intratumoral therapy, and the TB needle injections have been used as a chemotherapy with cisplatin. And the EBUS needle has been used to inject the medicine into the desired area of the lung cancer or into the lymph nodes. So this transbronchial needle injection and the drugs to be injected into the tumor itself has been used to inject the chemotherapy. Endobronchial liposomal amphotericin B in symptomatic aspergilloma has been used by specifying, demarcating with the EBUS and injecting the liposomal amphotericin B. Even in AIMS, they have tried voriconazole in aspergilloma. Another beautiful paper is there for the transvascular needle aspiration. So CP, EBUS, TBNA, or across TBNA, the transvascular or intrapulmonary artery needle aspiration by Ravinder and Mehta, they have published a series on the transvascular needle from our Indian literature, and to do or not to do transvascular needle aspiration. A beautiful paper is by Pirathur A.N. Another beautiful indication of EBUS is in lung transplant. EBUS has been used to evaluate the airway and osmosis in lung transplant recipients. A quantitative assessment of bronchial mural structures in lung transplant showed that EBUS can discriminate different layers of bronchi in humans and to measure the thickness of these layers in a reproducible fashion. This is one of the newest indications when I was going across the literature. So it was worth mentioning that EBUS beyond mediastinum has expanded its wings. Diagnosis of lymphoma. A beautiful editorial by Atul Mehta. Still it is a debate whether EBUS TBNA material is enough for diagnosing the molecular typing of lymphoma or diagnosis of lymphoma, but definitely it is a very good tool. When this was written, the gold standard was mediastinoscopy. Now we have further tools to diagnose and help diagnosis of lymphoma by achieving from various modalities the material from lymph node, which will help you to clear-cut diagnose. Issue is the tissue, and tissue is the issue, so you need a tissue, and when you are able to get the tissue, I think EBUS helps there to have the tissues which we will be discussing as the discussion will go there. Cryonodal biopsy by our Hari, who has pioneered this, making a hole with the 19 gauge needle into the lymph node and 1.1 mm probe of the cryo, you are able to do the mediastinal lymph node cryobiopsy, having an adequate tissue for the diagnosis of any disease where the mediastinal lymph nodes are involved. This is a paper and a series of the case reports, 4 or 5. You can go through it because I cannot put it here all to discuss. Another beautiful indication of radial endobronchial ultrasonography combined with transbronchial lung cryobiopsy in patients with diffuse parenchymal lung disease. It was a multi-center prospective study. The two signs have emerged. The dense radial EBUS sign correspond with consolidation on HRCT, then blizzard sign. So when your radial EBUS is there in the consolidation part of diffuse pulmonary lung disease, when you get a consolidation, you get the dense sign. And in the diffuse pulmonary, without consolidation, you get a blizzard sign. This was a study, this is the normal radial EBUS pattern. This is what you call snowstorm. This is the dense sign when you enter into the consolidation. This is a blizzard sign when you are in a diffuse lung disease. This is the consolidation. When you put your radial EBUS probe here, you get the dense sign, and this is how the material you get. This is the blizzard sign you will get in diffuse pulmonary lung disease. We know the 2018 IPF did not advocate the TBLC for the diagnosis, but in the present study, the higher pathological confidence of specimens in patients with dense signs than in patients with blizzard signs have proved. And now, as per the latest guidelines and the latest publications, the cryo lung biopsy is in for the diagnosis of IPF and the DPLD. So, to summarize, mediastinal vessel evaluation, transvascular needle aspiration, pleural and cardiac lesions, pleural pericardial effusions, thyroid lesions, intratumoral therapy, or the indication. What are the novel devices that can improve EBUS TBNA and future perspective? You have the acquired 20J needle, which is equipped with 3 cutting edges. You have ProCore needle by the Cook, has a core trap to have the material for histological samples. You are able to go through the same hole which you create with the 19 gauge needle, the intranodal forceps biopsy. You can have the biopsy itself of the lymph node, which helps you to diagnose the diseases like sarcoid and lymphoma. Another novel tool is the transbronchial cryobiopsy, which I have mentioned, wherein a 1.1 millimeter cryobiopsy probe is inserted in the hole created by TBNA with a 3-second freezing time, and you meet the whole instrument in total.
Dr. Okay.
I am stopping here. This is the last slide. I am not talking about complications. We can talk later on in discussion. The expert in anything was once a beginner. Thank you very much.
Thank you so much, Dr. Chawla, for a very enlightening talk. I think we've all learned so much about it. Actually, you've actually shown that, imagination, the sky is the limit. If you start imagining where all an EBUS scope can be used, it's just mind-boggling completely. Anywhere and everywhere, any situation and every situation, EBUS can come handy. Now, to discuss about this and more, we have a galaxy of stars that we've collected this evening for all of you. And Dr. Chawla, you'll be happy to know that we have 2,000 plus, or I think 2,100 delegates this evening who are listening to all of us on this panel this evening, on this webinar this evening. And they've come from all parts of the country to listen to Dr. Chawla and the panelists that we have this evening.
Under the leadership of Dr. Vivek Nangia.
No. My job is very simple, only to be asking questions and nothing else this evening. So I guess just a minute, let me just get this right. Okay, perfect. So let me start with introducing our first panelist for this evening, who is Dr. Prince James. Prince James is head of interventional pulmonology, a very bright, very distinguished, very accomplished pulmonologist himself. He started the thoracic ultrasound services in the respiratory medicine department way back in 2009 when probably it was just introduced into the pulmonology field. He's had 36 publications, contributed to book chapters as well, and conducts regular thoracic ultrasound and thoracoscopy annual workshops since 2004 or 14 probably, I would presume. So Prince is very, very active pulmonologist, and it's really an honor and pleasure for us to have him here with this evening. And I'm sure he'll really contribute a lot to this panel discussion. Next, we have none other than Dr. Sameer Bansal, all the way from Bangalore. He is a DNB, EDRM, IDCCM Senior Consultant Clinical Head of Vayu Chest and Sleep Specialist, Associate Professor, Apollo Health. Again, very brilliant, very bright, deeply involved into the various interventions, and very impressive work that he has. More than 45 publications at such a young age in books and chapters and national and international journals. And his areas of interest are asthma, ILD, BPF, hemoptysis, TB, and peripheral pulmonary nodules. Thank you so much, Sameer, for joining in this evening.
Thank you, sir.
Then we have all the way from Nashik, Dr. Abhinandan Mutha. He is an MD in pulmonary medicine and currently working with KIMS Manavata Hospital as well as the Mutha Hospital. So I'm presuming that's his own hospital, and he's doing his own good work. So again, he has lots of work to his own credit, interventions doing regularly, very dynamic, very inspirational for the youngsters. So as you can see, we have a very young crowd today, this evening, to discuss with you all. And next, so we have Dr. Anand Vijay. He basically comes from Rajagiri Hospital in Kochi, a very famous hospital. And I was there recently to attend the NatCon last year, which was very well organized by them. He's a consultant interventional pulmonologist and has won the Dheeraj Gupta Young Investigator Award in 2023 during BronchoCon, the JC Kothari Young Scientist Award, and the state level NCCP quiz winner, which is again very, very prestigious. 5 publications in national and international journals, young, bright, brilliant, accomplished. So we have a complete galaxy of stars this evening. And let me start with the first question right away without wasting much time. With just give me a minute. Where have I got the question? And let me tell you, I need to thank Dr. Mehul Thakkar for contributing to these questions. He's the one who's actually sent us all the questions, although I did go through them and thought that, maybe there's some changes required, but I really couldn't find much that I could add to it. So let me ask the first question to Dr. Prince. So Dr. Chawla has already highlighted, but I just want you to recap that what are the current indications for EBUS?
Yeah. Thank you, Dr. Vivek, for kind introduction. And thank you, ICS, for inviting me to this wonderful webinar on EBUS. So we all heard a wonderful presentation by Dr. Chawla, and I think all of us have learned a lot. I will just summarize quickly to save the time. So when EBUS came, the first indication was diagnostic evaluation of mediastinal lymph nodes. And then we can do lung cancer staging. That was the first and the 2 most important things which we did. And then now it is anything which is peribronchial or peritracheal or even periesophageal lesions can be accessed by this. So liver, adrenal, pericardium, or the pleural lesions also being.
I guess some network issue, we've lost him. Dr. Chawla, would you just like to just remind them that what are the current indications for EBUS? One, of course, is the mediastinal lymph nodes and the mediastinal masses.
Definitely. See, we know it has been introduced for the mediastinal lymphadenopathy initially. But with mediastinal lymphadenopathy, whether tuberculosis, sarcoid, or lymphoma, or cancer, these were the main primary indications for the EBUS, and you are able to access. Later came is a cancer stage. Please, Prince is there. Prince, continue.
No, I'm sorry. I think some link got broken.
No issue.
So where was I? So I think Dr. Chawla has already given wonderful presentation. I'll just summarize again. The major indications with the EBUS were diagnostic evaluation of mediastinal lymph nodes and lung cancer staging. These are the two main things which we are doing. And then we expanded to anything which is peribronchial or peritracheal or periesophageal.
I think he has a poor connection this evening. So basically what we're trying to say is that, as I said in the beginning itself, that sky is the limit.
Pulmonary nodule as well. Yeah.
So it's not just the airways, not just the parenchyma, but even the vessels. And beyond the chest, you can even go up to the liver and the adrenal glands.
Sure.
So, Dr. Sameer, what structures can be assessed and sampled apart from the mediastinal lymph nodes, I guess?
So I think first of all, thank you so much, sir, for that introduction. So again, whatever the EBUS can see, whatever the probes can see, we can assess actually. So if we start from the beginning, from the neck onwards, the thyroid nodules, we go inside, you have various endobronchial lesions. So just to assess the vascularity for those lesions, the vessels around there, just to see, okay, whether, that there's any pulmonary thrombus, as Dr. Chawla also rightly pointed out. You go ahead, you sample, you can see the parenchyma as well, especially the central lesions, the lung abscesses or infected bullae. You can see endobronchial lesions such as doliphos also, various, and then when you start going into the esophagus, you can again see all the paraesophageal nodes, you can see the left lobe of the liver, you can see the left adrenal gland as well. Finally, you can also take a look at the pericardial effusion, the intracardiac clots or vegetae or maybe tumors or something, as well as pleural masses and nodules. So ultimately, there's a lot of things which can be done using an EBUS when we're especially focused on trying to sample the airway and beyond the airway as well.
Right. So, Dr. Abhinandan, so far we've been using the classical TBNA needle, 19 gauge, 21 gauge, 22 gauge. But if you look at the studies, they haven't really shown any difference in their yield or the outcomes. So, what do you think are newer and complementary tools that have been developed to obtain biopsy specimens? Because ultimately you realize that TBNA is usually not sufficient. Needle aspiration in any indication is not sufficient. And, the histologist always wants more tissue, more tissue, more tissue. So what are the complementary tools that you can use for a histopathology?
Definitely, the tissue is always the prime importance. We do the procedure to have maximum of tissue. So basically, the studies have shown that the size of the needle doesn't matter, but there are newer. So if we have for diagnosis nowadays, we require molecular testing and everything if it is a cancer, and for if it is my infection, we require to do cultures, the AFB cultures and gene experts. So definitely, we require more tissue. So for that, the cryoprobe is being used, which gives maximum tissue compared to the needle aspiration. And it gives us a chunk of a tissue which gives us more histopathological diagnosis rather than aspiration and cytological diagnosis. And also the newer needles and in radial EBUS also now they are using it with the PeriView needle which has recently been launched.
But what about the conventional transbronchial biopsy forceps? Have you ever tried pushing that into the lymph node and taken a biopsy from there?
Personally, I have not tried a forcep because initially we did it with the needle and now with the cryo. So no, not tried the forcep as yet.
Yeah, so you can use the smaller biopsy
Or the
forceps.
biopsy forceps. Yeah.
Yeah, for taking a biopsy from there. So, there's always so EBUS TBNA was basically for detecting lung cancer, staging of the lung cancer, to avoid mediastinoscopy. So, Dr. Anand, how do you increase your yield from diagnosing and staging malignancies to getting enough tissue for IHC and mutation? That's very important these days for the molecular mapping of the cancer and for their genetic makeup to be able to decide whether the patient needs to go in for a chemotherapy or whether the patient needs to go in for an immunotherapy. So, ultimately, again, the question comes down to increasing your yield and increasing your tissue. So, how do you think for cancer especially you can increase it? We can't hear you. Can you unmute yourself, please?
Simple thing what we can do is first you combine the rows if possible, so that the pathologist, if he's there or whether the sample is adequate. And other biopsy techniques are also which we can do to increase the yield, like our biopsy techniques, like needle biopsy techniques, then forceps biopsy and the cryobiopsy. In case of linear EBUS, for the radial EBUS, whatever available tools, still the diagnostic yield is coming only up to some 80-85%. We can combine with the fluoroscopy, then we can combine with the a thin bronchoscope, ultra thin bronchoscope, then virtual navigation to exactly point out to the nodule. Likewise, we can actually increase the yield.
Right. So I think rows is a very, very important step. Whether you're doing an EBUS or doing a conventional TBNA, in both the situation, if you have rows, then there's a greater likelihood of reaching a diagnosis, because it'll keep giving you an real-time evaluation of whether you are reaching a diagnosis or not. So while some people may be hesitant in doing rows, so what I suggest for them is that you can always have a cytopathologist as a backup, as we do. We send our slides to the cytopathologist who's just 3 minutes away from our bronchoscopy suite, and who instantly goes through those slides and reverts to us that how does it look like. So that saves a lot of effort, and you don't need to keep poking the patient repeatedly for into the lymph nodes. So, Dr. Chawla, coming back to you now, you were talking about lymphoma and how you can increase the yield of tissue for lymphomas. So, how do you think the approach has changed, and what are the current tools that you recommend should be used?
See, Vivek, the EBUS TBNA is an established thing for the lung cancer staging. But for the diagnosis of lymphoma, also it is a very, very important tool to help you to suspect lymphoma. As I said, the tissue is the issue. You need more tissue to have substaging or histologically subclassifying the lymphoma, like Hodgkin's lymphoma, low grade and non-Hodgkin's lymphoma, high grade and non-Hodgkin's lymphoma. So you want low grade or high grade Hodgkin's and non-Hodgkin's lymphomas, you need a tissue for the immunohistochemistry and the markers. There is a small study where the 8 patients, and they have shown 87% cases they could subclassify lymphoma even with EBUS TBNA 22 gauge needle. But now when you have a transcryo-nodal biopsy, making a hole with the 19 gauge needle, the hole is sufficient. I will like to share with you. You get, when you are opening a radial probe, there is a forceps in that kit of the radial probe. And that forceps is a very small forceps. And you can actually use that forceps for the transnodal biopsy, which we are calling as an intranodal forceps biopsy. Cryo 1.1 probe you can use. Then, as I said, you have newer needles by the COPE, which is the cutting needle, and the Procore needle, where you can get a more tissue. And when you have the more tissue, EBUS with these newer techniques and the availability of the instrument have made the life easy. Otherwise, EBUS only for the diagnosis of lymphoma had always been debatable, because the required tissue is, with different studies, is a different experience.
Absolutely, because lymphoma requires a very large chunk of tissue. It just can't be based on a cytology that you diagnose it to be lymphoma. So therefore, it is important to use the newer tools for its diagnosis. Otherwise, earlier patients would be subjected to a mediastinoscopy only for a diagnostic purpose, truly. So, this was about the airways and the mediastinum. Dr. Prince, I wanted to take you to the next level now and talk to you about the pleural sampling using EBUS. How do you really do that?
Yeah, that's an interesting question. I'll just say one line on rows. So actually, we can learn rows, and I think papers also got published. So it's high time that we should start learning. We just have to identify a granuloma and the atypical cell, only that much. And so I think some WhatsApp rows also some published. So that is also one possibility. So it can be used in more easier way nowadays. Coming to the pluralism, that's so interesting and wonderful question. So I'll try to put it in perspective. So if there is a pluralism, And especially something like mesothelioma malignancies, the primary gold standard investigation is thoracoscopy. Second can be image-guided biopsy. So thoracoscopy can be done safely, even with a minimal effusion or no effusion. So that is also possible. So if we have to choose an investigation, we'll go for this. But where EBUS fits to diagnose the pleural lesion. So sometimes there are occasions where you really can't do thoracoscopy, or lesion is sitting something like a mediastinal pleura adjacent to esophagus or trachea, and that's the only lesion over there, and probably you can easily access that lesion through the EBUS scope. In those cases, I think more than 20 cases have been published in literature where people put the needle over there and diagnosed mesothelioma, sometimes malignancies and all. So those are the typical indications. But I will again say, there are pleural lesions. First thing we should try to do is a thoracoscopy and fix the diagnosis. And similarly, sometimes with the patients who are, some pleural disease has been done and recurrence happened, you can access via the EBUS scope. So those are the very typical indications, but the lesion should be near the esophagus or trachea.
Right. Thank you. So, before we go on any further, I'd like to remind all the audience this evening that please keep putting in your questions if you have any. We'll be happy to answer. You have an opportunity to speak literally to the people who are doing it themselves day in and day out. So they'll be able to answer you better than you have to look it up in the net or in the books. So this is your opportunity to connect with them, and don't miss this opportunity. So without hesitation, keep putting in your questions and we'll take them up after this panel discussion. So coming to you, Sameer, now, we just heard Prince talking about the pleural lesions. What about the adrenal and the liver lesions? How simple or difficult are they to reach and access?
So, yes, I think a lot of people, I think initially when I also started doing it, initially I was quite fascinated. Okay, the scope can reach all the way up to the liver and you can actually access that. But then, and with all the nuances associated with how to go about it, how to plan for it, is it going to be very difficult? How does it look like? But then actually, if you're used to doing ultrasound, you know how each of these things look, it actually becomes quite simple. One thing, because when you're entering the esophagus, it becomes very easy out there because there's a lot of space and all. So typically, our experience with sampling liver and all, although we used to do it quite a lot earlier, majorly to look at those lesions and maybe a couple of times biopsy it also. Now we've reduced doing it, but certain things that we do have to keep in mind is one, the anatomical landmarks. What exactly is, how to rotate your scope. So typically what we start doing is 3 landmarks which we identify is as soon as we cross the diaphragm, just rotate the scope to the right side and there is the left lobe of the liver. Look for all the hepatic veins, use a Doppler, and you can see that classical sign which you see otherwise on a transthoracic ultrasound as well. And sweep the whole thing to look for any suspicious lesions. Finally, when you rotate it slightly anteriorly, you can see the abdominal aorta and the celiac trunk also. And finally, as you keep coming backwards around the greater fundus of the stomach, you can approximate and see the left adrenal gland also. And look at that classical sign, as Dr. I think Chawla also put across a very nice image over there. So that is how you can look at it also. So certain things which we just have to keep in mind over here is one, the anatomical landmarks, the length of the scope, and finally, whether you can approximate in the stomach to all these structures around that particular region. So when you go ahead with all of this and when you maybe do 2 or 3 cases, it becomes easy. Now, when you're about to puncture all these lesions, that is another challenge. Assess for vascularity properly. And once you've done that, you make sure, okay, the lesion which you're accessing or trying to biopsy is not really vascular. I think safely you can go ahead and do the puncture and the cytology, if not a biopsy.
Yeah, so basically, I think what is important is to differentiate a vessel, identify the vessels and stay away from them. That is extremely important as a message that must go. But please remember, all these procedures can only be done after a certain degree of experience and expertise. These are all procedures which are not really like the usual ones. So they can lead up into complications also. So you must have a backup available, and you must only do it when you're absolutely confident of doing it, not otherwise. You should not be experimenting just like that. So pleural and pericardial effusions is another indication where EBUS is now being introduced. Of course, so far we've been doing pericardial taps and pleural taps, but sometimes that is not sufficient or not possible. So, Abhinandan, what is your opinion about this concept of drainage of pleural and pericardial fluid using EBUS?
Yes, sir. Means whenever transthoracic approach is not possible, USG guided transthoracic approach, if it's not possible for draining of pleural or pericardial regions, and as sir all mentioned, and also for the peripheral, the pleural masses that James sir mentioned, that if it is amenable through and the border is touching the trachea or the esophagus, we can have a transtracheal or a transesophageal approach to drain the loculated effusions that are not possible through the transthoracic approach.
Right. So is it like easily done, or it require, again, of course, it requires a lot of expertise that goes without saying.
Of course, sir, of course.
Right. So, Dr. Anand, next I wanted to ask you was Dr. Chawla was also mentioning about this fiducial markers which are used for malignancies. So, would you like to elaborate on that?
Yes, sir. Actually, this EBUS can be used in various therapeutic procedures in cases of malignancies. The first one is this fiducial markers, which we can use to identify the nodules on the mediastinal nodes, which we can actually stain with dyes like ICG or methylene blue. And so that if we are planning a surgery, the surgeon can easily locate the nodule, as well as for brachytherapy also it will help. The other indications are like we can actually assess the submucosal areas very well, better than even CT. In some literature, it is saying that EBUS is much more better than CT in assessing the submucosal areas. So we can assess the extent of the tumor, and so that the procedures like the tumor debulking, mechanical debridement, hot therapies like APC, laser, everything can be performed by assessing with this. And the vascularity can be also assessed so that we can safely do the procedure without making any life-threatening bleed. Another indication which I found that which is published in 2019, which was saying about in case of malignant nodes, this is that what it was chemo agents like cisplatin, etc. can also be considered by using this therapeutic method of EBUS in malignancy. So extent so that the length of the stent can be assessed, everything that in that way also we can use EBUS.
Right.
So, sir, if I can just comment on the use of fiducial markers as well.
Yeah, sure. Please, Amit.
Yeah, so one of the things to notice, or rather, because nowadays a lot of focus has been on lung nodules, and especially when lung nodules are being picked up. So this is especially where we've seen a lot of times our thoracic surgeons also going in for all these surgeries and then actually missing out the nodule and then coming out. So that is where the bronchoscopic use or maybe a CT guided placement of fiducial markers is becoming quite important. Now, the thing over here to note is, okay, it is only valid if we are going ahead with, say, robotic assisted or a VATS biopsy where you cannot really palpate the whole thing. If it's an open surgery, then it is not really required. But when you're going for either a VATS or a RATS, that is when you can actually help in marking this with all these fiducial dyes or methylene blues or whatever.
Right. So, Dr. Chawla, what about the mediastinal cysts? Do they really? We've had a couple of patients where we did it, but the cysts came back. Do you think it's like it's like a permanent kind of an option, or surgery still remains the choice?
Absolute correct, Vivek. I will like you to go through a topic. Should asymptomatic bronchogenic cyst in adults be treated conservatively or surgery? It's a beautiful study where 683 adult patients were treated of bronchogenic cyst, and around 79% were having symptoms. They treated them surgically. Even rest of the 79 patients, asymptomatic, also underwent empirical surgery to prevent the redevelopment of the symptoms. and confirm the diagnosis. To surprise only 0.7%, 5 cases out of 683 were having the malignant cells in the cyst wall. Primarily, it is a benign etiology which tends to recur. Surgery remains the choice, but when patient is surgically unfit, he cannot undergo the surgery. Yes, EBUS walks in, it helps you to drain, provided you have the follow-up that patient regularly and agrees to visit you regularly, then EBUS guided drainage of the cyst becomes the procedure of choice in surgically unfit patients.
Right. So basically, it is only for the surgically unfit patients where you would want to do it. Otherwise, if it is causing major symptoms and you want to relieve the patient of instantly of the symptoms and surgical backup is not available, then also maybe that will be an indication. But surgery still remains the treatment of choice if it is, if the patient is symptomatic because of the cyst. So, Dr. Prince, we heard Dr. Chawla talk about the use of EBUS in the diagnosis of pulmonary embolism. Well, the cases that have been reported are more incidental or accidentally, detected. They were done for some other reason and they found it to be pulmonary embolism. So, do you think it can emerge as a diagnostic modality in a patient who can't really undergo a CTPA? Now, for instance, somebody who has an acute kidney injury or a chronic kidney disease and has a high creatinine and you can't give contrast. So far we've been using the ventilation perfusion scan. But do you think time has come where we can use the EBUS for diagnosing and pulmonary embolism also?
Yeah, I totally agree, Dr. Vivek, that I think 2010 we purchased the EBUS scope, so around 15 years. We haven't used it for primarily diagnostic indication, as you have rightly said, to diagnose pulmonary embolism. Patients so much sick to cannot be shifted to the for CTPA, and if it's hypoxic, whether you or the IC team would allow you to put a scope in the endotracheal tube to diagnose this becomes a question. However, yes, incidentally diagnosed, but it's a good modality to see the thrombus directly. So especially when there is kind of a, as Dr. Chawla said, that pulmonary artery sarcomas and all, which very difficult to access and very difficult to biopsy by any other modality, and EBUS comes very handy. So there is the primary use, and sometimes cardiac tumors and all. But embolism, yes, still incidental finding, and sometimes it is useful finding because if it happened between the CT scan and your EBUS procedure, you are able to diagnose it and provide right treatment to the patient. And
Also,
sometimes, yeah.
Also, I think it is basically the major vessels in which you can diagnose in the EBUS, but not in the the small
segmental
vessels and the
arteries.
segmental
Yeah,
arteries.
you
You
can't
possibly can't reach there. And again, you can't reach the upper lobar arteries either.
Yeah.
Of course, it has been, so as I said, it was more of an incidental finding that they got while they were exploring something else. So, well, we've learned that there's another, there's something more, some additional benefit of using EBUS in these patients, but to be using it for diagnosing of pulmonary embolism may just be a little too far-fetched.
True.
So, we've talked about the mediastinal cyst, we've talked about the pericardial effusion, pleural effusions. So, Sameer, I want to ask you, what about lung abscess? Can lung abscess also be drained?
So, yeah, I mean, lung abscess, again, theoretically speaking, yes. And practically
Does that
speaking, a
help?
lot of people, practically speaking, a lot of people have done it also. I mean, this is going through the literature. Personally, not done any of those. So again, what they call it is the EBUS guided transbronchial lung abscess drainage. So in general, yes, they have tried to drain peripherally located lung abscesses also. I mean, I would logically think a centrally located lung abscess may be much more amenable to drainage rather than a peripherally located one. But the meta-analysis, one of the studies which I was seeing wherein they have used EBUS to drain it. So in fact, 40% of those were all peripherally located lung abscesses. Now, although what they decide is typically small to moderate size abscess, because I think the larger ones definitely go for a surgery upfront. So the small to moderate size, which the patient is not either very symptomatic at that point of time, possibly you decide to venture and just try and go for it. and majorly uncomplicated abscesses, like no significant bleeding or there's no necrosis in these particular subsets. Okay, maybe if you want to be a little more adventurous, you can try for it. But then, if this is the case, many of those heal spontaneously with the help of antibiotics, prolonged antibiotic courses also. So, do we actually go inside and drain this is a huge debate, but can it be done? Yes, it can definitely be done. So what they also say is that for a peripheral lesion, you can use a guide wire to access it and then advance your EBUS scope through it. And once you're there, you just put in either a larger gauge needle, maybe a 19 gauge needle or a catheter through that and try and drain it out. So these are certain things, and the advantages, of course, when one thinks yes, it's minimally invasive, so it may reduce the risk of complications and need of a bigger procedure such as a proper surgery or something like that, and of course can cause lead to faster recovery. But then I would rather wait, be more conservative for these smaller abscesses and give an antibiotic course, and if it's a larger one which requires surgery, just go for it.
Absolutely. So, Abhinandan, we were also talking about thyroid lesions. What about thyroid lesions? What is your opinion about them?
Definitely not the
Very
first.
rare.
Definitely not the first choice of this, because transcutaneous approach is definitely easier and easily available. But definitely, if you want to see whether the thyroid mass is invading the trachea or not, the cartilages whether are involved or not, and definitely would be useful if the mass is retrosternal and into the mediastinum and not approachable through the transcutaneous approach. So there only I think the EBUS scope and EBUS guided thyroid biopsy would be helpful.
Right. So, as innovations continue and there's always a search for newer and newer things, newer devices, there are newer inventions in EBUS also that have happened. So, Anand, would you like to highlight some of them? Or what are the newer innovations in EBUS scopes that are?
Sir, the newest, as we all know, the three companies are producing the EBUS scopes like Olympus, Pentax, and Fuji. The Olympus has come up with the 190F series scope, which is the newest one, which is actually more thinner, more flexible, and which is having a more perpendicular needle entry compared to the old 190F scope. And this 190 scope, which is actually not require balloon most of the times, like many of the times, maybe around limited conditions only may require a balloon. The 190 scope actually required balloon most of the times, which for the position and all. So that is one difference and advantage. And the newest ultrasound processor, which is the EUME3 processor, which is introduced with this Olympus, which is having this elastic mode, THES, that is tissue harmonic enhancement penetration, that is P, and S mode, which is all having more quality of image, and we can distinguish the image between more clearly. So this all helps in the more proper and more good procedure as well. And this Pendax is actually coming up with a new scope, which is supposed to launch in March, which is actually a HD scope with a smaller size and latest sensor. And a unique point that they are telling is that this is having a twin mode, like a live video and one reference image in the split screen. So this is not launched yet, and they are also having multiple radial probes, multiple sizes like a 2.6, 1.7, 1.4, and 1 probes. And this Fuji, the latest scope is having more good vision, and a 10-degree forward oblique vision is only there. So it is almost all kind equal to our routine conventional bronchoscope. So these are all the newer advantages of the newer scopes which is available in the market.
Right, very good, excellent. So, innovations never really stop. The human mind never really stops. You want more and more. You have something, you start with a small car, then you want a bigger car, then in the car itself, you have newer innovations being added onto it. Now you have the electric cars. So it's something like that. So, Dr. Chawla, now switching gears from adults to pediatrics. What are the common indications and patient selection for EBUS in the pediatric population? When would you really do it? I mean, so far we've been diagnosing tuberculosis in those patients in the kids based on the MON2 and lymphadenopathy, and you would start them on ATT. But you think time has come where we can use EBUS in these patients also? Please unmute yourself.
Correct, Vivek. The indications primarily remain all what I have or Prince has elaborated in indications of adult EBUS. Diagnosis of mediastinal lymphadenopathy, as said, tuberculosis, lung cancer, lymphomas, sarcoidosis, a disease on suspicion of Mantoux cyst, and the symptoms you have been treating. Now, EBUS has expanded to the children. Trachea remains an issue because of its narrowness with the age. Not too many people are using it, but yes, there are studies, a few from USA, UK, and India from All India Institute of Medical Sciences, using the EBUS as USB FNA, even to the younger child, as in USA they have used from 2 months to 4 years. The studies of the 10 children where EUSB has been used for diagnosis of mediastinal lymph node, tuberculosis, lymphoma, and all that. While in India, even 3-year-old has been used by Karan Madan in All India Institute of Medical Sciences, and they were suspecting on CT lymphoma, and these 3 children of 3 years of old were diagnosed to have tuberculosis. Another series of 2 cases of 9 years old and 10 years old who presented with fever and cough. Again, the suspicion was of malignancy. EUS-BFNA and EBUS-TBNA in these older children have helped them to diagnose the granulomatous disease. Trachea remains an issue, but same EBUS scope with EUS-B technique can be helpful. This has got its own limitations of availability of lymph nodes through EUS-BFNA, but station 7 remains the choice to puncture and get to the diagnosis. In the newer development of EBUS, pediatric scopes are on the way, and we look forward. Dedicated EBUS for children should be available as the pediatric bronchoscopes are available, so that without any hesitation you can use those scopes. Maybe the ultra thin EBUS, which are walking in for adults for the peripheral lesions, will make a way for the children, so that you are able to access their airways also with these EBUS scopes. I'm not touching anesthesia, how you do it, because Prince James is going to talk about it.
Right. So, Prince,
Yeah.
what do you think, are the challenges in these patients basically when you're dealing with kids? What about the anesthesia, the airway contours, what preparation you need? And what about the tracheal size? Isn't that a limiting factor in these patients?
Yeah, I totally agree. First, the limitation was our that awareness among pediatric friends, because most of the cases were going to still surgeons and they were doing mediastinum. So I'll say, but EBUS came really handy, and once our pediatric colleagues came to know that we do it, and it's really useful, as Dr. Chawla rightly said, that cases of children proved to be tuberculosis while they were considering lymphoma. There is no other way of diagnosing those cases. Challenges are, if the kid is something like 12 year or more, you can use tracheal part. Also, if you're using LMA, you can go inside the trachea. It's big enough to for the current thinner EBUS scope by Olympus. However, if the age is younger, means 3 years, even 1 year, it can be done, but we have to use the esophageal pathway. We can use that. Ventilation can be done in the trachea through the ET tube also, because you're not using trachea now. So ventilation can easily go through that, and we can go into the esophagus and do it. Yes, lymph nodes accessibility will be little bit a limit, but most of the time, subcarinal or paratracheal are there, as they are most common lymph nodes get enlarged. So the chance of getting diagnosis remains high.
Right. So what is the least size of LMA that can be used in the children?
Actually, sizes are, you can use the IGL too, but what usually we do is we keep the scope there and ask the anesthetist to pass the LMA beforehand. So once they pass it, they are happy, we are happy, then put it that. So that's the most practical use. Yeah.
So, Samir, do you need special accessories or special needles to for these children, or the same ones can be used?
So principally, I think, the basic principles of the procedure remain the same for both adults as well as the pediatric population. But again, all these cardinal differences, yes, smaller airway size, and possibly more fragile airways. So that is something which has to be kept in mind. So with that, yes, there are certain things which are there, which are already developed and which are coming in pipeline. So one is the smaller endoscopes, I think, which Dr. Anand was also talking about, the 190F series, which is slightly smaller, 616. I don't know how much difference does that make in a pediatric airway, but still. Second thing is the balloon itself. Typically they may require a smaller balloon size to avoid overinflation and potential airway damage. So typically 5 to 7 millimeter balloons may be used in the pediatric age group as compared to the 10 to 12 inflated at lower pressures, also at 1 to 2 atmosphere, I believe. The smaller cytology needles, the 22 to 25 gauge needles, would be much more preferable for them. And many times they also use, when you have to go a little distally, possibly some balloon dilators are also available, so that that can help in passing across your EBUS scope. But I think, as Dr. Chawla mentioned, the easier would be to just go and do the EUS VFNA, which would be much safer in these population until you get even thinner or slimmer EBUS scopes for this particular population.
Right. So basically, this EBUS in pediatric population is on the anvil now and is going to be the next topic for discussion for the next couple of years till it really becomes popular in our country. And I'm sure the day is not far where every center will now start, housing an EBUS for the pediatric population as well. So, Abhinandan, now, whenever you do a procedure, it is very important before doing the procedure, the indications and the contraindications, the complications. So, what are the complications you feel or you think that they can be while doing an EBUS in children, and how to handle them?
Complications are similar to doing a bronchoscopy and a EBUS. But in the bronchoscopy, we definitely use a pediatric scope, so hence they are lesser. If you do an EBUS to the trachea, then definitely the damage to the vocal cords and the airway is more just due to the size, because we don't have the pediatric scope. But if you do a esophageal approach, then these complications will be lesser.
Right. So I guess the complication would be similar to what you experience in the adults.
Adults, yeah.
Something like in remote chance of developing a pneumothorax, infection of the lymph nodes, any kind of bleeding, those kind of things only, but nothing unusual really that is reported.
Similar in adult and pediatric.
So, Dr. Anand, what do you think is the future of EBUS now? Is it only limited to diagnosis, or we can extend it to therapeutics as well?
So from this on our discussion, it's always like it is the sky is the limit. So definitely it is not limited to the diagnostic purpose, and EBUS is a must nowadays. Like almost like if you take your OPD, if 50 patients comes, at least some 5 patients requires EBUS or any other diagnostic procedures. So and coming with a more aggressive management in the oncology section as well, this EBUS is definitely going to make more changes in the management of oncology and malignancy, like this fiducial dye markers and everything is going to be a game changer. I think already Nagarjuna sir started using it, fiducial dye, for nodule localization before surgery. So like that, actually without much additional investment, we can perform all this, like this iodine application to the mediastinal nodes, intratumoral injections and all. Actually, we can also try, and definitely the future of EBUS is going to do that level.
So from the time, sorry. Yes, Dr. Chawla. Dr. Chawla has come back absolutely fresh after a quick bite.
I will definitely endorse what Anand is talking, but at the same time, I have given you the true figure. If you want me, the different manufacturers, how many scopes are in the country, I analyzed that out of 415. 415 for a 140 billion population. And you said out of 50 patient OPD, 5 people are of mediastinal lymphadenopathy. These all scopes are in metropolitan cities, the first tier cities, and few are in second tier. Where goes the 3 tier city and the population? you must not forget the conventional TBNA skill. You become more skillful when you do EBUS and you are tuned for conventional TBNA. So conventional TBNA you should always practice before jumping on to the EBUS TBNA. That will help your data improve even in CTBNA. So to the youngsters, have a Mercedes, no problem, but Maruti still drives you to the destination. And in a population of 140 billion, can you imagine EBUS 415 in the country? Out of that, 15 Delhi and NCR. What is the fault of the rest of the population? So in all workshops, when you attend, and you must learn the methods of CTBNA, and before doing EBUS, do the CTBNA, keep those slides separate, do EBUS TBNA, your skill and your yield is going to improve in CTBNA. So when patient is poor, you can offer, because now you know the anatomy, your imagination where you have to puncture, it's going to help your patients with the cheaper option of giving them the diagnosis.
Exactly.
This is my personal opinion.
Exactly what I remember, Dr. Chawla, you reminded me when I told my son, when I was teaching him how to drive, and I told him, okay, pick up the automatic car and we'll go out driving to this morning. His response was, Dad, I need to start from the manual car first. What if the automatic car is not available sometime, and I should still know how to drive a manual gear system. So it's exactly like that. So you have to start from the basics only and then upgrade yourself. So that brings us to the end of the question that I had to ask the panelists, but we are open to questions from the audience. And before that, I'd like to thank the 2100 plus audience that we have this evening for joining in. So please don't hesitate. Keep pushing in all your questions. We're all here to answer your questions. So the first question that we have that has come to us is, just give me a minute. I think this is the first one, huh? Okay. So Rida from Jaipur has asked the question, and I'll put it to Dr. Prince, that what role does fluoroscopy play in EBUS beyond the mediastinum?
I think if we are going for a peripheral pulmonary nodule, a fluoroscopy is useful because we want to see where are we going and how to direct our probe, radial EBUS probe and bronchoscope over there. So a thin bronchoscope, a radial EBUS probe and a fluoroscopy is a good combination to reach the destination. Though the caution is it's two-dimensional, so a CBCT is more preferable, which can be a three-dimensional, and you can see the tool in lesion. But it's useful over there. But for conventional, for CT EBUS, you directly see the ultrasound image, and the lesion you don't navigate via the fluoroscope.
Yeah, but when you're doing newer things, newer procedure, it's always helpful to have a fluoroscopy also available to you, especially when you're doing it for peripheral lesion, as you said, especially subpleural lesions and all. There is no harm in having a fluoroscopy also available. So I always believe that, the more the tools available, the more you start utilizing them, and the better the results always are. So the question next is from Mumbai. Nita has asked that what are the challenges in accessing subpleural lesions? Samir, would you want to take that question?
Yeah, so again, the subpleural lesions, of course, when we also perform a radial EBUS, again, going back to the basics, the closer the lesion to the center, it's always better. So the further the lesion away from it, it's always challenging, because you always have to see, okay, which segment and the subsegment is leading up to it. So always look at the CT scan more properly. Because if you can demarcate, okay, which particular segment is going to it, you are likely to get a positive result out of it. So that being said, it's not always possible, because sometimes when you give anesthesia also, there is some amount of atelectasis also that happens. So there is a discordance or rather divergence from your tool and the lesion as well, even if you're using a fluoroscopy. Of course, newer techniques that are available are the CBCTs and the VBMs and all, which really help in confirming the tool and lesion. But these are some of the challenges that are there with all these subpleural lesions, especially when you're accessing through a radial probe EBUS. Now, as we were also discussing using a curvilinear probe EBUS, if yes, maybe you have a large lesion and you're going for an say EUSB FNA, and you have a large subpleural nodule, that may be accessible, especially if it is abutting the esophagus at some point. So these are certain challenges and I think intricacies that one needs to keep in mind while accessing these distal subpleural nodules.
Right. So, Dr. Chawla, I'd like to ask you the next question because you're the senior most on this panel this evening. So you'll be able to guide us onto the learning curve. That how is the learning curve different for EBUS guided sampling of mediastinal versus peripheral lesion? And this question has come from Shahbaz from our own Delhi.
The learning curve for mediastinal and peripheral lesions, you must learn to identify the images of the lymph node, images of the parenchymal lesions, how they look like. EBUS which is used a part of the EBUS, which is a radial probe, the lesions identification is different. You know that you are in the lesion or the lesion is on the sideway. You must understand to identify the shadow of the lesion and the ground glass haze, which is normal. So these two radial EBUS and the linear EBUS images are totally different. With experience, you are going to gain and identify the lymph nodes, identify the vessels. As I told you, it's not a very big game. Two vessels on the right side, two vessels major on the left side, two major lymph nodes, 4L, 4R, and 7. It gives you 80% of your diagnostic modality. You are able to see the pulmonary artery. There is no embolus, as you rightly said. People have incidentally diagnosed pulmonary embolism by seeing the pulmonary artery and retrospectively started using EBUS in critically ill patients where you are suspecting pulmonary embolism. So you need to identify the floating thrombus or the wall of the artery is involved and you start thinking about sarcoma. So you need to have first assisted EBUS at least in 30 to 40 cases, learn to identify the linear images on different structures and identify at the time of it, make a chart, make the things the size of the lymph node, homogeneity of the lymph node, round or oval, nodal structure, that it oval or totally round, it is going to help you to see it is benign or it is malignant. So when you are doing the linear scanning, similarly you start doing the radial EBUS scanning, what kind of an image we are seeing and what we are going to expect. So these are both are going to help you in learning the EBUS for peripheral lesions and for the central lesions with the linear and with the radial. Apart from this, on behalf of the organizer, 2134 logins, I am very happy to see. If 500 are postgraduates, I promise your abstracts will be published in Lung India. Please send them to NAPCON Pune. This is a young NAPCON. We want to see the youngsters walking in the corridors. And that is what stimulates for the seniors and the teachers to teach all of you. And as has been said, the galaxy of people will be there for you to meet. So these youngsters, my appeal is rush your entries to NAPCON 2023. Thank you. It is apart from this, it is my interest, so I have spoken. With permission from Vivek, retrospectively.
So next question comes from Gujarat. Bhavyaja has asked that what safety consideration should be addressed when using EBUS for sampling peripheral vascular lesions? Anand, would you like to take that question? Peripheral vascular lesions.
Yes, sir. First of all, we need to check whether any major vessels are coming near to that. If it is absolutely necessary to sample such lesions, we can do it. But before that, always keep your gadgets for controlling the bleed ready. Like keep your rigid ready. and the Fogarty, everything has to be in place before performing biopsy, especially cryobiopsies. If possible, do it. If peripheral, we can do it with a sheath, and forceps biopsy will be ideal. If not possible, then if you are doing cryo, all these things should be kept in hand.
Right. So Nida from Mumbai has appreciated Dr. Chawla's talk. She found your talk very informative, sir, and so did we. Very, very informative and educative for all of us this evening. Now, next question comes from Pune. What are the limitations of EBUS TBNA in diagnosing retrocrural lymph nodes? Abhinandan, this question has come from Gaurav in Pune. TBNA in diagnosing retrocrural lymph nodes.
Approaching the retrocrural area is only the issue, because
Yes.
you have to go look into it posteriorly. I think if not possible through the tracheal approach, you have to see the esophageal approach then. So diagnosing and localizing the crural lymph node would be much difficult, and if once localized, then sampling it would be the same.
Right. So Prince Kundan from Bangalore would want to know that how do thinner EBUS scopes improve access to smaller airways or peripheral lesions? You muted yourself. Please unmute.
Yeah, thinner scopes came really handy because as we started with the this 4R4, LN7 group of lymph nodes, gradually all of us realized that probably you can width the scope in the segment, sometimes even sub-segment it can reach if it's a thinner scope. So really useful for all peribronchial regions. Sometimes malignancies, nodules are sitting over their masses and you can directly sample it. There is no other way of accessing it because surrounding, if it is the lung, then transthoracic is very difficult to cross the lung and reach there. So EBUS scope was really, really useful, has been all these years in accessing those things. So the more thinner the scope, the better your access will increase.
Absolutely. It's like the thinner, the better. You were able to reach right till the periphery and take the required material from there. Rida from Jaipur has found this panel discussion very, very informative and engaging. Thank you, Rida, for joining in and for your kind words of appreciation. And also, Bhavyaja Gujarat wants to thank IAB for this initiative on EBUS. So I'd like to convey the message to the President, Vice President, Secretary. President is Dr. R.P. Meena. Secretary is Dr. Amita Nene, who doesn't know her. She's literally the star of IAB now and has been leading the show for the last couple of years or more than that, probably. So we always are very grateful to her for leading the academic march of IAB. Next question has come from Chennai, Sohan, and this I'll address to Samir. What are the benefits of using convex probe EBUS over a radial EBUS?
So I think there's nothing of a benefit or one over the other. It's more like different indications for both of them, and where these can where the reach is for the both of these. For all the central lesions and of course your larger lesions and whatever you can access in the main bronchi and adjacent to the main bronchi, I think a convex probe EBUS is much more beneficial, and going to the of course the oblique nature of the needle that passes through and the transbronchial puncture that is required. So that is where the convex probe EBUS comes in handy. And of course, with all the various indications that we spoke about, the EUSP, FNA, all those places, this becomes quite handy. And when we are talking about a very peripheral nodule, that is where, of course, your CP, the convex probe EBUS can't really reach. And that is wherein your radial EBUS comes in really handy. So it's majorly the lung nodules that we currently use it. Of course, we also use it sometimes for, just to assess the depth of or rather the invasion of the mucus by the tumor as well. So these are certain advantages which a radial EBUS gives in peripheral nodules and to assess the invasion of the mucosa over a convex probe EBUS. But again, each one has its own indications and can't really differentiate or rather, put one over the other.
So Mangesh from Punjab, Anand, this question is for you. Would like to know that how is artificial intelligence, AI has really added a lot of value to our lives. AI is there in practically every field now. So do you think AI also would have a role in enhancing the EBUS image interpretation?
Please.
It's like you put an EBUS and it starts saying that, okay, there's a lymph node or there's a vessel.
So, basically, if anything says that this is the diagnosis, still we need to sample the node. So that is a fact. If we can use AI to differentiate some features of the lymph node, which may aid in the diagnosis, like which may help in the differentiating the lymph node. That's it. Otherwise, we need to definitely sample the node. That's it. I think that is the role.
So AI basically can guide you, cannot give you a diagnosis.
Yes.
Ultimately you will have to puncture, you will
Yes.
have to be careful. So AI can only guide you and add value to it in terms of making your procedure more safe and more
Yes.
precise. Prince, would you?
It can
No,
help us with those, I think.
Prince is itching to say something. Please, Prince.
I'll only say that we are moving in that direction, and at present that's the only role that can do. But we are dreaming, or we are thinking that a day comes that machine learning becomes so deep that it can identify the pattern on the ultrasound and can tell us that this is malignancy and this is TB or this. So a day will come. So the studies are saying that deep learning is so deep that what our eyes, human eyes, see, the machine has started seeing more deeper, and we do not know what they are seeing. That's difficult to interpret, but they are able to see. So as we keep feeding them, a day may come, yeah, you can fix a diagnosis with the radiology.
Yeah, but
Sir,
not.
I think it might help us in the rows also.
sir,
If you do
can
a
I
rows,
talk a little?
AI may help us in rows.
Yeah, but at the same time, it still doesn't replace a doctor. So
Yeah.
always, you will still be required to be there. However advanced AI may be. Shehbaz has found this session very informative and feels that combining well-structured and relevant content, and has thanked the IAB for such a wonderful webinar. Thank you, Shehbaz. We appreciate your comments. Next question goes to who have I not asked? Abhinandan. Abhinandan, the next question comes to you. What is the role of elastography in EBUS for differentiating benign and malignant lymph nodes?
I haven't, sir, majorly used elastography. I have a EME1, so I have limited knowledge about it. So,
Okay. I will give the answer of this. I will add to what Prince was talking. This is what is a confocal laser endomicroscopy is walking in, where you can see the histological images that can improve the targeting of the tissue sampling, so that you are able to see what kind of a malignancy or it is a benign tumor, even on the scope when you are watching the mucosa. So confocal laser endomicroscopes are available now. To add to the elastography, it's a real-time non-invasive strain imaging technique. So you have the color patterns of blue and the green, and you have to measure the benign from the metastatic lymph node, means benign or the malignant. There is a scope which is from one company which is giving you the elastography, and the presence of metastatic infiltration on elastography is the increase in stiffness. So when the blue image increases, this tissue is more stiff, and the sensitivity is 88 and specificity is around 85% in detecting these malignant from benign lesions.
So basically, something like what you do a fiber scan of liver, this is
Correct.
something that is able to give you, depending on the density of the tissue, you are able
Correct.
to decipher whether this is malignant or benign.
Yes. This is with the color coding of blue and green.
Yeah.
So more the blue, it is more stiff. So that area comes on the image when you are having like an ultrasound and you switch on that elastography mode and you see the color pattern, you are able to see it is a stiff node predominantly or it is a softer node. So this is how you say it is benign or malignant.
Prince, Manoj from Hyderabad wants to know that how does robotic assisted bronchoscopy integrate with EBUS for a better diagnostic precision?
Yeah, I think our radial EBUS probe is the final holy grail of that diagnosis of peripheral pulmonary nodules. So whatever we use, whether you use a robotic arm or our own arm and reach there, ultimately it's the radial EBUS which reaches there to the peripheral nodule, and on the screen it shows, yes, there is a lesion there. So you have reached there. So then after that, robotic is actually useful because the angulation and the precision improves with the robotic. So where we can't reach or we can't negotiate our scope, or scope doesn't bend, and with the needle scope bending becomes more difficult, robotics are more bendable and they can reach and they can turn at 90 degrees to collect samples. So very useful. It's coming up. Yeah.
Samir Omkar from Kolkata wants to know that what are the key limitations of EBUS TBNA for diagnosing lesions in the lower lobes of the lung?
Again, as I mentioned earlier also, so one of the major problems that comes with EBUS, I mean, the peripheral nodules especially, I assume that is the question in the lower lobes. It's majorly with the divergence. Okay, once you give an anesthesia, there is a band of atelectasis, and when you actually go inside with the radial EBUS, and you may know, I mean, you may feel okay, you are actually into the lesion, but you may be out of it. And of course, the fluoroscopy gives a 2D image, so you can't really make this thing out. So I think one of the major limitations is this. So second thing is, of course, the branching patterns which are there, because sometimes it's again related to the same concept, because what you look on the CT scan and you map your airways, the particular bronchus which goes up to it, and when you're actually on table and it does not really match. So that divergence is the major limitation, in my opinion, that happens in the lower lobes, because the atelectasis also happens majorly in the lower lobes, lower lobe area.
Omkar, you start using, when you are learning radial EBUS, put in these lower lobe lesions, put your radial EBUS, localize the lesion and leave the sheets there, take the biopsies. Because they are the major lesions, you will start identifying the consolidation with the dense signs with the radial probe EBUS, leave the sheet there and take multiple biopsies. You will be very happy.
Right. So Amresh from Surat, Anand would like to know from you that how do you ensure safety when performing EBUS lesions on structures which are adjacent to the blood vessels?
Control of the needle is more important, sir. When like if there is a major vessel, and if you are doing TBNA from a lesion which is near to that, the control of the needle is more important, and always do it under direct vision only. If you're not getting a proper vision due to non-opposition of the EBUS, try to get it opposed properly, then do it under direct vision. That's it.
So it is very important to be able to differentiate the blood vessels, and if you're trying the transvascular needle aspiration, it has to only come with experience, and you can't be doing it just randomly and brazenly. So you have to be careful.
Amresh, if you are a beginner, stay on the right side. Don't venture. Expertise. People are not that they have done transmuscular 10, 20, 50, 100 cases. 1, 2, 4, 5. These are the word reports. So when you are not getting diagnosis by any means, then switch on to these approaches of transmuscular, that you are a hero, that you did 1 case or 4 cases or 2 cases or 3 cases. So stay on the right side if you are a beginner. Venture on the left side when you are expert and identifying, as Vivek has said, the vessels from the structures.
So Abhinandan, Dinesh from Jaipur would like to know that what factors determine the choice between EBUS and a transthoracic needle aspiration for peripheral lesions? Well, I guess it's quite an obvious choice.
Obvious. Basically, if the advantage, I think, is more that if we do it bronchoscopically, we can take lavages and biopsies both. So take for investigation purpose, it helps us to distinguish between infections also. If it is air bronchogram is more visible, then bronchoscopic is better so that it minimizes the chances of pneumothorax. If it is a dense mass, both are preferable.
So in any case, if it is easily accessible from peripherally, you would always prefer doing a CT guided biopsy, which is simpler to the patient also, as compared to going into the EBUS route, which is of course more technically more challenging and also more expensive, and yet is not like 100% indication as a simple CT guided biopsy would be.
Yeah.
I think first choice would still remain that only. So, Dr. Chawla, that what role does EBUS play in diagnosis of congenital anomalies? Ketan from Mumbai has asked you this question.
Ketan, first, since we are the adult pulmonologist, congenital anomalies of the lung, if they are related with the central airways or the peripheral airways, then you can use if they are vascular anomalies or they are the other anomalies of the lobes of the lung or the segments of the lung or physiology or anatomical variations in the segment. So you need to have those images, and if you think the pediatric patients, the congenital anomalies, we personally don't have much experience of using the pediatric EBUS for these procedures, but there can be physiological variations of the lungs. You can use a pediatric bronchoscope, while the EBUS for having the congenital anomalies. You have the CT, you have the echocardiography to tell you the congenital anomalies and role of EBUS. When I was searching, I could not find in finding the congenital anomalies in the pediatric population. Main indication of EBUS remains what we are having in adult population.
Right. Very good. So Prince, Vishal from Delhi would like to know that how do you optimize image settings for smaller anatomical structures during pediatric EBUS?
I think if we are doing an EBUS, mainly what we see is we want to see the vessels, we want to see the lymph node, and we should know where is the lung A lines are coming and the sliding pleura. So as far as setting is concerned, mainly your gain and all, and it is same like an ultrasound setting. So your gain should be such that it shouldn't be too black or too white, and whatever we want to see should be in the middle of a screen. So that's the depth that's how we adjust. So these are the few things which we keep in mind. Where is the focus and how deep we are seeing and what we want to see. With that, it can be done.
Right. So basically, you have to keep it in the center. You have, it's like the fish's eye. क्या मछली की आंख जो होती है, that archery competition by Arjun. So if you remember that. Okay. So Samir, Aditya from Gujarat wants to know that what innovations in EBUS scope technology have improved navigation in complex airway anatomy.
So I think currently, whatever we just spoken about, one, yes, maybe the thinner scopes. So ultimately, thinner the better, the further is your reach. That's one. And secondly, with all these elastographies and all, just to see, okay, whether the airway is more stiff or the structure that you're trying to access is more stiff, or is it more elastic, whether it is amenable to your simple TBNAs, or whether a biopsy may be more feasible. I think these are the only things. Rest, mostly the innovations or rather the advancements which are there have really been to reach the nodule, which is with the help of, say, robotics or cone beam CTs and maybe the thinner scopes. So this is currently what is there. And as far as the EBUS scope per se goes, I think it's just the thinner scopes and the elastography which has come in.
And of course, the navigation bronchoscopy itself, that can also add to the yield and add to the advances. So before we go on any further, again, I'd like to remind you, Dr. Chawla has already invited you all, and so has Dr. Mehul in the beginning, to the NAPCon 2025, which is being held in Pune this month end. So we'd love to see all of you there and add value to the conference. It is going to be a huge show that the Pune team is putting up in such a short time, and we are all very looking forward to it and excited to be a part of this landmark conference that is going to be held in Pune. So before I take a question from Pune, Ajit, I'd like to say that Manoj from Hyderabad has found the discussion very insightful, and valuable perspectives have been shared throughout. Thank you, Manoj, for appreciating. So Anand, the question that Ajit from Pune has asked us is that what are the current challenges in implementing robotic EBUS in routine bronchoscopy units?
Definitely cost, sir. I think we cannot bill the patient around some 1 lakh or 2 lakh for a diagnostic procedure. That is the one major limiting thing from implementing this robotic thing.
Right. So basically, I think it's the cost only. Cost availability is what is a major limiting factor when it comes to adding technology. So next question is from Amit Kiran Rath from Thane. Abhinandan, he wants you to elaborate on the procedure by moving the trachea, paratracheal lesions sampling. I'm not very sure what he wants to know.
I
I
think,
guess
I think he might be asking the video which sir showed that while that moving the trachea. So Chawla sir had shown a video. He wanted to see the video, I think.
where he has moved the trachea.
Correct. There is a paratracheal lesion which is not abutting the trachea, but he's able to show the image of the parenchymal lesion. Here, if you little more pressure put on the plunger and press the EBUS probe, you reach near and the trachea moves. This is what you have to do. Abut the ultrasound probe to the right lateral wall or the left lateral wall, wherever is the lesion. Abut, create the image after putting little more pressure on the wall. You are more lesion near to the lesion and then press the needle in. You will be able to sample it.
So Amresh, thank you for your appreciation. You've also found this very engaging, practical, and thought-provoking. Thank you, and we'll convey your message to IAB also. And we will continue to hold these kind of webinars in future as well. So Akshay from Indore, Kiran from Chennai, and Jitesh from Punjab, they want to know, Prince, whether you can access liver lesions and adrenal lesions also through EBUS.
Yeah, I think it was shown in our initial presentation by Dr. Chawla beautifully that, yeah, left lobe of liver and adrenal lesions can be accessed, and a number of people are doing it. As and when the definite indication there, yes, possible through esophageal pathway.
So Akhil from Bangalore has become really very interested in pediatric EBUS, and he wants to know, is there any company which is manufacturing it in India, or is it available in India? Pediatric EBUS scope. Do we have
No,
any?
it is not available. Still, you are looking for the ultra thin EBUS scopes which you can use. But EOS B technique with the EBUS scope is the answer as per today, from the neonates to the adults, with a very good anesthetist. As Prince has said, the conduit and the feasibility, because the procedure is to be done under GSA, GA with the ETCO2 monitoring. And when you are doing the passes and removing the EBUS from the EUSB from esophagus, that gives, if the ETCO2 is not available, the time for the ventilation to maintain. But still, that scope for specifically EBUS for pediatrics is not available.
So Hemant also had the same question, whether there's a reliable company manufacturing EBUS or not. He's from Hyderabad. Kalpesh wants to know if a liver lesion can be accessed, which we've already answered. Harish from Ajmer wants to know whether we can access pericardium with EBUS. Yes, we can, Harish. And liver lesions, of course. So this is an interesting question which has come from Surat, from Bilal. How to get rid of alveolar epithelial cells? Abhinandan, alveolar epithelial cells, and get some lymph node tissue in TBNA needle. Please give some practical tips.
Vital step is that we have the stillet inside. So when we push in, then we have to and fro movement of the stillet. That because of that, we don't get the alveolar cells inside. So once we are inside the node, then only take out the stillet back so that the alveolar cells does not come in.
Right.
Practical issue, the truthful question, in spite of doing all this, you still get negative samples, you still get epithelial tissues, pathology says not adequate. You say I was in the lymph node, but lymph node tissue is not there. This is the practical. The more you practice, the more you will do, the more accurate and more your yield will increase. As Vivek has said, how to increase the yield, the webinar on how to increase the yield. This is one of the practical tips, experience and things to improve. All of us are facing the same issues. So that is how you will be doing more. It is a very challenging thing. You need a dedicated pathologist. You learn. Sometimes if all of the lymph node you are not able to puncture, so you are getting epithelial cells. You are in, you have not dislodged properly. Even doing everything, still you get the epithelial tissue.
Right. So Prince Mangesh from Punjab wants to know that how peripheral embolus in right or left pulmonary artery can be diagnosed. I think
Once you are inside and reach the lower part of trachea and start seeing, and you suppose you are seeing the 4R lymph nodes in the right lower paratracheal wall, and then you slip down towards the right main bronchus, you start seeing the pulmonary artery, and similarly the left side. So once you start seeing them, it's not difficult because inside the vessel, if there is an echogenic shadow, it is seen like an ultrasound image. It's actually an ultrasound image, so you can make out that this echogenic opacity is sitting inside the blood vessel.
so. Sameer, can we access pot spine abscess also using EUS BNA? This question has come from Ashish from Ajmer.
I think so. I mean, I'm not very sure, not really read about it also. But I think if it's large enough and possibly if it's adjacent to the esophagus, possibly. I'm not really sure
And
about
I guess first choice still would be a CD-Gyre
exactly.
and CD-Gyre aspiration. If not possible, then yes, you could use it also. If it is paraesophageal, then why not? You could try that. Except that it may have the risk of leading into some kind of fistula into the esophagus.
Fistula, yes.
So you'll have
विवेक इन बच्चों को सोचने में क्या जाता है? सोचने से ही तो रिसर्च होगी.
सोचना तो है पर हमें जवाब भी तो देना है
Do
ना.
one question. We don't have honestly an answer.
हमें भी जवाब सोच समझ के देना है सर. नहीं देना वहां बैठ के.
उसने सोचा है उसने आपको जवाब देना ही पड़ेगा.
So I guess it's already 10:30. We have so many more questions coming up. So, but we'll still continue. Although Dr. Chawla has had a bite in between, we all are still hungry and waiting for our dinner to happen. So we'll still continue with it. So next question comes from Manoj in Hyderabad, and the question goes to Anand. Then what are the challenges in accessing subpleural lesions using EBUS? You'll have to unmute yourself.
Thanks, sir. So subpleural lesions basically from trachea, it is little bit difficult to access. So by using EUS, it is little more easy, but this is the main limitations basically.
Right. So of course, it's not easy to be accessing the subpleural lesions using EBUS, but if needed, then you can. Omkar wants to know, Abhinandan, that can EBUS replace surgical biopsy for staging extrathoracic lymph nodes in malignancy? Well, it already has, I guess.
Already.
We replaced it now. We hardly use any surgical staging now any longer, or a mediastinoscopy for just staging purposes. No, we don't. We use the EBUS only for this purpose.
He's asking for extrathoracic. I don't know why.
Extrathoracic lymph nodes, meaning axillary lymph nodes.
I think possibly the retroperitoneal lymph nodes using an EUS-BFNA approach.
Again, EUS-BFNA can be reached. So anyway, so the idea here is that
approachable by an EBUS that can replace a surgical biopsy.
absolutely.
But approachable by an EBUS scope, not.
So Amresh from Surat wants to know about fluoroscopy in EBUS beyond the mediastinum. We've discussed that already. Dinesh from Jaipur, what are the indications for performing EBUS to sample adrenal glands? Prince? Adrenal glands indication. Basically, any adrenal tumor or any adrenal mass
Correct.
would be an indication.
At that time, and if the metastasis is only sitting there or you want to make an M1 diagnosis, yeah, you can go there and sample.
Ketan now wants to go into the next question, that what is the diagnostic yield of EBUS FNA for adrenal metastasis? Ketan, you have to understand there's not like a routine procedure that is being done. It's only innovation that, it's just coming up that, okay, you couldn't reach the adrenal any which way. You've done the EUS FNA and have reached there. So we don't know what it's not like large randomized controlled trials or large studies that are available to talk about the diagnostic yield. Just that it is another modality that can be used for accessing the adrenal glands if you're not able to reach there any other way. Pune se Jayesh Sawantji wants to know that what are the limitations of EBUS for assessing the right adrenal glands compared to the left? Prince, right versus left. Dr. Chawla all this while has been saying stay on the right, stay on the right.
Left side.
Slide
I
or
say
that's
on the
also
right when you are doing the EBUS. You are on the left when you are doing EUSB FNA. And only left side the adrenal is visible. In cases of CA lung, 7% have got a metastasis sitting. The literature speaks of LAG, left adrenal glands. So, right bhi hota hai adrenal gland, but I do not know how to approach. You are approaching through USB and a left adrenal gland.
So Omkar from Kolkata has found this to be a great discussion with clear takeaways and valuable expertise shared. Thank you, Omkar, for your appreciation. We have Anand's question next, all the way from Thane, that what are the anatomical landmarks for identifying the left adrenal gland? So Dr. Chawla has already highlighted it.
Eagle side.
Naveen from Punjab wants to know that does the position of diaphragm affect visualization of the adrenal glands during EBUS?
No.
No. Mohan from Jaipur wants to know that kindly make a note about the use of EBUS in aspergilloma. You were talking about, Samir, you were talking about draining a lung abscess. So can you also drain an aspergilloma from that abscess?
So I think yes, literature does talk about it, okay, especially when you have an aspergilloma, which is very symptomatic and maybe intra cavity installation of amphotericin or something. That is something that can be done, but people have done it transthoracic approach also and otherwise also. But again, not a routine procedure. I think what most of the people are currently focusing on are adrenals, pericardial, pleural fluids, and all of that. So these are all very just in extended use. These are not routine indications also. And the first choice always would be something which is very symptomatic, maybe go for a surgery and resection of that particular aspergilloma.
Right.
See, as Samir is talking, the definitive treatment is surgical resection. If patient is unfit for surgery, then you are talking by means how to reach to that aspergilloma cavity, putting a voriconazole, putting amphotericin B, and these are not, as Vivek has said, the randomized trials or decided. These are the few cases, few people across the world, not in the country, have done. So this is literature says that you can use as an extended indication of EBUS, but it is routinely recommended no.
Right. So Anand, what do you think would be the most common complication associated with EBUS guided liver biopsy? Rida from Jaipur has asked this question.
Sir, I have no personal experience with the EBUS guided liver biopsy, but I think bleeding is the one thing that we need to address during liver biopsies, even other modalities also. So that will be the one major complication which is associated with this EBUS guided liver biopsy.
Right. Plus, if it's a abscess or something, it has a potential of rupturing into the abdominal cavity. So, those are and of course, jaundice, transaminitis, hepatitis, those will be the usual complications. Nida from Mumbai wants to know that how do advanced imaging techniques like confocal microscopy integrate with EBUS in clinical practice? Abhinandan? Or maybe Dr. Chawla would want to answer this. He was talking about confocal microscopy.
See, this is a new development, very expensive. It is available in the world. You are able to see the mucosa and the pattern of the mucosa, whether this lesion is a benign or it is a malignant. So before, as on EBUS, you are able to do the morphology of the lymph node, the size, structure, round, oval, heterogeneity, homogeneity, nodal, lesion is there or no, it's benign or malignant. Similarly, you are able to see with this confocal microscope attached with the EBUS, the bronchoscope, that the lesion visible is benign or it is malignant. This is what you get and help with the confocal microscopy.
Next, we have some few questions, but I think we've already answered them. That what will be the choice for a peripheral lesion? Should it be transthoracic or EBUS? Does the diaphragm movement during respiration affect the visualization of liver lesions? Dr. Chawla has already answered that. How to optimize imaging setting? We have answered that. What are the key limitations of EBUS TBNA for diagnosing lesions in the lower lobes of the lung? Mangesh from Punjab, very inquisitive mind. Samir?
So I think we answered the same question. So the major limitation in the lower lobes of the lungs, especially, is, I mean, when there is a very small lesion, maybe a nodule or something, it's associated with the atelectasis of the lung, which is generally associated with the anesthesia, especially because initially for a learning curve, general anesthesia or deeper sedation is what is preferred. And that atelectasis itself can mimic the lesion, especially on the radial image. So that is something which is there. And finally, the complex anatomy, which is also there. So just look at those CTs, and major takeaways, be very meticulous and obsessive about that CT scan and airway mapping. And once you do that, and initially, if you are on a learning curve, always try to do localization for larger lesions before proceeding to the smaller lesions.
So Ashish from Ajmer has asked that how does EBUS guided liver biopsy compare to percutaneous or transjugular approaches? So again, Ashish, same thing that we've answered and we've been saying repeatedly, that one, it's not like a standardized procedure. It's one other additional tool that is available to us for reaching the liver abscess, liver biopsies. Ideal would be a percutaneous route or a transjugular route. So Manoj from Hyderabad, Anandji, he wants to ask you that how does the use of cryobiopsy via EBUS improve the diagnostic accuracy for certain lung disease as well? Just by increasing the size of the tissue, it increases.
Basically, we will get a more good chunk of tissue with less artifacts. That is the one thing. Like in any other modalities of biopsy, like a forceps biopsy, the tissue, the artifacts will be there. Pathological artifacts, bleeding artifacts, etc. will be there. That will reduce the quality of the sample as well. In TBNA aspirate, like previously we have discussed, some even whatever we have done sometimes, only in the aspirate we will get some bronchial tissue, bronchial epithelial cells, and only there. So cryo, if you put cryo, definitely that if tissue is there, definitely that tissue is of a very good quality, and that will suffice for everything, including all the ancillary studies and everything.
Right. So Omkar from Kolkata wants to know about the fiducial placement in planning for stereotactic body radiotherapy. I think we've discussed that already. Jayesh from Gujarat has found this very focused discussion, interactive, highly informative, and is thanking and is grateful to the IAB for such fantastic webinars. And all faculty are fantastic and superb discussion has happened. So I'd like to appreciate all of you here this evening, and a big round of applause for all of you. Virtual applause, of course.
Thank you.
There are just a couple of more questions that we'll take up before we finally round it up for the evening, which has now actually moved into the night. That Saket from Jaipur wants to know, is there any role of M mode ultrasound in EBUS? Prince, you've been doing a lot of ultrasound.
Yeah. No, as far as we never applied M mode in the EBUS ultrasound. So you use M mode actually to see the motion along the time. So that was not the EBUS indication mainly.
Right. So I think when we said in the beginning that, sky is the limit, people have actually taken it very seriously. And there is a question that has come from Bhaumik, Mumbai. Sameer, that is there any experience of putting EBUS scope into the pleural cavity also now?
Not really. I don't have any experience.
Oh, no.
When we started our thoracoscopies, we
There
started
are
doing it with a
people
bronchoscope only.
who put bronchoscope in pleural cavity, or it's very difficult to answer you that EBUS in pleural cavity, what EBUS is doing when you have a thoracoscope, dedicated thoracoscope for the pleural cavity. Otherwise, choice, as he has said, sky is the limit for your choices.
Yeah, exactly. So maybe a time comes where you're able to reach the paravertebral abscesses and pod spine with the EBUS scope and be able to drain it through the pleural cavity. But of course, you need to have an associated fusion or an empyema along with it. Otherwise, it'll be difficult to reach there, or a pneumothorax. Creating an artificial pneumothorax for it. And finally, another question which is very innovative, coming from a very inquisitive and intelligent mind from Akhil in Pune, that is EBUS helps in localizing hemoptysis in advance. Dr.
Yes.
Char, the final question to you.
Yes, Delphi lesions, you must suspect. If your patient is a case of hemoptysis, you should not bite anything what is visible on bronchoscopy. You must keep in mind Delphi lesions. very dangerous to touch, and you can have a massive bleed and the death on the table. You have to be very, very careful here, where the EBUS is helpful in diagnosing the cause of hemoptysis.
Right. So that brings us to the end of this panel discussion. I'd like to thank each one of you for your very valuable inputs and putting this great show together. As I've already been reading out all the messages in between, that there's been a lot of appreciation from this 2100 plus gathering that we had this evening. And this is all evident from Dr. Amita Nene's smile and that she's into our platform now. So it's really a pleasure to have you back with us, Amita. And thank you so much for giving us this opportunity, and Mehul for setting up all the questions and setting up this entire, the webinar, which has been truly appreciated by everybody.
Thank you very much. Thank you so much. Thank you so much, dear faculty, each of you all. Dr. Vivek, Dr. Chawla, Dr. Prince, Dr. Sameer, Dr. Abhinandan, and Dr. Anand. Thank you so much for this amazing, most brilliant, fantastic academic treat. I have heard every word of this webinar, and believe me, I have learned just so much, and it has just been amazing moderation by Dr. Vivek Nangia. Dr. Rakesh Chawla's talk was absolutely fabulous. I mean, I would say it was one of the best I've ever heard. Fabulous talk.
Dr. Chawla or otherwise also? I'm just joking, sorry.
Yeah. I mean, Dr. Chawla's talk today, I thought was fantastic, one of the best. Yes. And Dr. Prince, as always, very, very modest, but always speaking words of wisdom. And I'm so happy our boy Sameer, who trained with us from Nair Hospital, he's, we share a common alma mater. He is really creating waves in Bangalore with his fantastic work. We have Dr. Anand, who's done our IIB IP fellowship, who has been absolutely brilliant in his work. He himself has started IIB IP fellowship, and he was superb today. And what to say about Dr. Abhinandan? He is our Nasik boy who does fabulous IP work. And we are just so proud, that we could present him to the entire country because he keeps so much of low profile despite doing fantastic work. I'm not saying much about Dr. Chawla and Dr. Vivek because we know that they don't require any kind of phrase because they are completely the KOLs. They make a difference to IP and they make a difference to pulmonology. I'm just so grateful to Dr. Mehul Thakkar, our IIB treasurer, who has made every module questions because it's a teaching program. There have been modules made and we made basically module questions from before, which have been given to our moderators, and our moderators also have been kind enough to, accept our questions and carry on. So thank you so much, Mehul, for this fabulous job. Nobody else could have done a better job. I would like to tell all our delegates that we've had a huge number, 2,143 logins today. And I give all the credit to our brilliant 6 faculty. It is their name and their photos on the flyer, which got us huge attention. And even at like 7 o'clock, we had more than 1,500 registrations. People were just so excited. Though it's a teaching module, this topic was a little hatke, and we thought students may not be interested in this, but we've had some 53 questions. So it is very, very obvious that everybody wants to know what they can do with the EBUS. And the best part is that we are actually getting consultants who are doing EBUS, who are also attending our webinars, and they're also coming up with fantastic questions. So I would just like to thank each of our brilliant 6 faculty for absolutely doing a jackpot webinar today. I think 2,143 logins is like something which we can never think of. And without the presence of 6 of you all, this would have never been possible. This was the last webinar of our IIB EBUS webinar certification course. The 10th webinar is over. We are lucky and grateful to each of our delegates for being so encouraging, for being so welcoming to us and attending in huge numbers. Every webinar has had 2,000 plus logins. When we did the thoracoscopy certification course, we thought we could never match the number of 1,700, but we've actually gone to 2,000. So we are so grateful to each of our colleagues, each of our younger pulmonology friend for supporting us, for encouraging us. And I be so grateful to each of you all. I would like to once again thank Dr. Mehul, for his fantastic contribution, because it would not have been possible without that. We have Dr. Rakesh Chawla, our president-elect. We have Dr. Vivek Nangia, our vice president, who have been extremely supportive. Our president, Dr. R.P. Meena, and our entire governing body has been just fabulous. They have been absolutely a lifeline, and we are able to do anything good only because of the support of each of them. So with this, I would like to say that we have concluded the 10 webinars of our EBUS certification course. We have 4 workshops, state-of-the-art workshops happening at the best 4 centers in the country. The first one is going to be with Dr. Vivek Nangia. The dates are fixed up, but we'll announce after a few days. So we look forward to huge attendance, just like we had thoracoscopy webinar workshops, more than 200 people in each. We look forward to huge attendance. We have enough EBUSs organized for each of y'all to have, full of practice till your heart's desire. I would really like to thank Mankind, especially Mr. Manoj and Mr. Nitin. Nitin has always been there for Mankind, without the support of whom we would have never thought of achieving huge numbers. Mankind has been our academic partner along with Olympus. Olympus has taken a brilliant academic initiative and they have supported us all through. So huge thank you to Mankind, especially Manoj and Nitin and Olympus. And with this, we would like to conclude our EBUS certification course. And I would like the faculty to just give some concluding remarks and we can stop.
Yeah, okay. So I think what is very important is the learning curve. These are all procedures that we discussed today. Accessing the various sites with the EBUS, they're not conventional. They're all non-conventional procedures. You need to have adequate experience, adequate backup available to you before you venture into all these procedures. So they're good to know, but difficult to practice and difficult to implement. But yes, you should know about them. And if required, if there is no other option available and you have the right backup, then go ahead and do them with the right kind of expertise available.
Dr. Chawla?
Start with conventional TBNA, learn conventional TBNA, do EBUS TBNA simultaneously, improve your efficacy so that the masses can enjoy the pulmonologist in the country rather than only the elite experiencing the EBUS. 2, start slowly, remain on the right side, develop expertise, learn to recognize the vascular structures of the left side, then only start puncturing. And I'm telling you honestly, 4R and 7, both lymph nodes with 4L, which you gradually learn, give you 80 to 85% of the diagnosis of mediastinal lymphadenopathy if you are puncturing with care, right? So then you can have to, today's webinar was totally exceptional for the parenchymal. As I happen to have one patient today, so I said, let me put it in this webinar. So you will learn to puncture wherever. See, it is an art of holding the EBUS scope. It is saying is easy that you abut there, you puncture there. When you are actually handling the scope, abutting to the adjacent areas, that is an art which you will learn with the practice. So keep doing and keep learning all these techniques with best wishes from us.
Thank you so much. Dr. Prince, over to you.
No, I agree with Dr. Vivek and Dr. Chawla that we should follow the guidelines, and EBUS is a wonderful invention and to change our practice completely. And I'm sure the delegates must have got a lot of benefit through this webinar, learned it, use it for your patients.
Thank you so much, Dr. Prince. Samir?
I think possibly a very insightful and a webinar for all the delegates. And the major thing is always learn to know your landmarks, anatomical landmarks when you're practicing EBUS, because that is something which is the most useful and helpful in avoiding the complications. And stick to the basics initially once you know that, and that is when all of this, whatever we discussed today, would make much more sense. Do not try to venture into the unknown without knowing the easier territory.
Wonderful. Dr. Anand?
First, I would like to thank IAB for organizing such a wonderful EBUS certification course. Amida Madam, Meena Madam, and Mehul Sir, and Vivek Sir and Chawla Sir for organizing and moderating this session and delivering this talk. Basically, this EBUS we need to go by approach it a step-by-step manner. Once we start localizing the nodes, then we can perform TBNA from larger nodes, then we can go to smaller nodes like that. If you do in a very step-by-step manner, we can expertise in a very good way. That's it.
Thank you so much. And now the master, the true master, Mehul, over to you. What would you like to tell in general about today's webinar and our entire certification course?
Ma'am, it was a great concept. You came up with an idea of a certification course, and look where we have reached right now. I mean, it is a wonderful feeling to know that people are actually enjoying it. It just came up as a small idea. And as far as the series is concerned, we view it as if I want to learn, if I was a student at this time, what would I would want to know from the speakers who are there? What would I want to learn? How to approach things? How are the basics? What are the small things which I might miss? And coming to the advanced webinar that we had today, Beyond Mediastinum was something which we didn't expect people will be so interested, but actually people, as Chawla sir said, sky is the limit. So people are asking, all kind of imaginations in their mind and they're asking it. And I'm very happy that it happened that way. And I'm truly thankful to all the faculty who have been very enthusiastic to be part of the webinar. And ma'am, your guidance has helped us to reach this state, and I'm sure we can do much more beyond EBUS and thoracoscopy in future.
Thank you so much. Very well said. I would just like to say one comment which came after Vivek started concluding. There's a comment from Nitin Ganthade. He's written, "Thank you very much, IAB, for this wonderful initiative. We had never imagined we could ever get such structured and brilliant teaching in IP in our country. Very, very grateful to IAB leaders." I think this comment sums it up. I think our initiative and our small idea has turned into a huge success. And thank you so much, everybody.
Thank you.
Thank you.
Good night.
Thank you.
Good night.
Good night. Thank you.
Everybody.